All right, good morning, everyone. We're going to get started. Today, I have the great privilege of welcoming Dr. Appa and Dr. Liu. Dr. Appa is an assistant professor in our division of HIV/ID and global medicine. She is also a clinical investigator who's triply boarded in ID, addiction medicine, and internal medicine. And Dr. Appa is the lead of the Healthy Access Point, which they're going to talk about today here at Ward 86. And Dr. Liu is the director of HIV prevention interventions at the San Francisco Department of Public Health. Dr. Liu is an HIV prevention researcher and also a provider in the Healthy Access Point here. Today, they're going to talk about this new Healthy Access Point, also called the Lobby at Ward 81. And this is really an open door to folks who are using drugs. And they're going to share cases from prevention and treatment and how they're doing this in a very low barrier way. So very excited. This is the first time they're talking about this at Grand Rounds. And so we're really happy for them to be here. So take it away.
Thank you so much for that introduction, Liz. Al and I are really thrilled to be here to talk about HAP today. Thank you to the brave souls who made it through the rain. And we'll really take you through sort of a case-based introduction to what HAP is, and spoiler that is on the slide, it is this status neutral clinic aimed to serve people who use drugs and people experiencing homelessness. And so we hope you take sort of a few pearls and a few practical, just have a practical introduction to what we do down on Ward 81. We have disclosures here. And to really get everyone just warmed up for the morning, just going to start with an audience response question. As a reminder, if you're joining in person or online, you can go to poll.ev/HIVGR and vote. The question for you to start us off is, what proportion of people who inject drugs in San Francisco are on PrEP? And for the test takers in the audience, I included a lot of decimal points to intentionally try to confuse you all. Is it, these are all, relatively low numbers, right? Is it 20.7%? Is it 11%? 5.3% or 1.5%? I'll give everybody a minute to think before I advance and log in. Okay, I have some votes here. We have a mix of a small proportion of optimists, respect, 20%, 20.7%, and then the majority of folks thinking 1.5% of people who inject drugs are on PrEP, with almost a third thinking about 5%. I love the spread. The correct answer is actually 1.5%, and I will let that sink in, as this really informs a lot of the work that Al and I do and everybody does that works on our team together at HAP. So, I think this is a slide that I believe Al may have shared as he taught us about PrEP last year, and that I have adopted from Dr. Erin Wilson at the San Francisco Department of Public Health. These are data comparing from the NHBS survey of people who inject drugs actually in San Francisco. And as you can see here, I'll draw your attention to the orange bar 2022. You can see that 55% of people who inject drugs in San Francisco were aware of PrEP in 2 years ago. So that's we have a huge awareness problem. And then as we move through the cascade, obviously we're at 1.5% of people actually using PrEP. But, I think one question for us all is, how do we increase awareness and utilization of PrEP among people who use drugs? So I think that leads us into what is HAP. Raise your hand if you've heard of HAP or know why it was founded. We have some people, I'd say the majority of people that I interact with are like, what is another acronym associated with HIV? And I'll say, so it's a health access point, and there are 7 sites across the city, and these were established by CHEP, the Community Health Equity and Promotion branch of the San Francisco Department of Public Health. And as you can see, there are different sort of thematic orientations of each HAP, including including ones focused on the Latina population, trans folks, and we are the HAP that is aimed at serving people who use drugs and people experiencing homelessness. And we're the only HAP that's embedded in a clinic site of note. The goal, as you can see in the bottom paragraph, is really to ensure that San Franciscans are equitably accessing high quality hepatitis, HIV, and STI prevention and care services in a sort of ideally stigma-free environment. So what happens at our HAP? This is our flyer made by the excellent Christy Camp sitting there in the back. We have the benefit of being co-located and learning a lot from our colleagues in pop-up. So we are in Ward 81 in the same team room as the pop-up team. We're open at similar hours, Monday to Friday, 1 to 5 for drop-in appointments. And as you can see there, our services are really aimed at, again, being sort of low barrier HIV and ID services for people who use drugs. So PrEP, PEP, STI testing and treatment, HIV care re-engagement, hepatitis testing and Hep C treatment, as well as substance use disorder treatment and harm reduction services. The model that we follow, without getting into sort of spending too much time on this, is that it's really a nurse-led nurse triage model in which the patient is lucky to be seen by our nurses primarily, who sort of triage whether they need a provider visit, and many patients are also have the opportunity to or link with eligibility, as for many patients is sort of their first interface with our system, and some with healthcare in general. We also have had and will have case management services and are supported by our phenomenal pharmacy team. So this is our flyer that we are constantly trying to disseminate. So if anyone actually isn't working in spaces that you think would benefit from just information about HAP, let me know. We will happily disseminate this to you. And a bit in the way of numbers. So since opening last year, we've seen 250 unique patients and started or ordered PrEP. There are sort of 77 patients in the PrEP orbit. I'll break that down for you. There are 30 patients on long-acting PrEP, 15 patients on oral PrEP. There are 21 patients who've started long-acting PrEP and then discontinued, who are currently inactive, and 11 patients who have a pending long-acting PrEP start. So folks for whom the sort of workup and plan has been made, but they haven't come back to start. So as you can see, I think like really exciting moves, and then also a lot to learn and I think a lot to work on. We've had 7 patients with their Hep C treated, and then 15 patients engaged that are living with HIV, and 10 graduate to sort of other care environments, primarily pop-up or panel at Ward 86. I'd say one other element or sort of surprise related to having this open door is that we've also been sort of really lucky to see a good number of folks that have recently emigrated to the United States and have learned about HAP as sort of a welcoming clinic. And so we've had the pleasure of seeing a number of monolingual Spanish speakers and linking them to primary care. And that's, just been another sort of side benefit, I'd say. One thing that I want to highlight while showing you lovely pictures of Christy and Cesar and Casey here is I just told you that 250 people have come through the doors, right? But what I think that doesn't really reflect is how they've come through the doors and when that has happened. When I started this year in February, I believe, I think we all were a bit nervous about the volume. It was lower just because you have built a clinic or have a low barrier environment. Does that mean people who use drugs will want PrEP, or that's going to drive them to walk through the door? And so I think that there have been a few different engagement strategies that, again, a number of others and our colleagues have we've learned from, but that have been helpful. And I just wanted to highlight. The first is making it comfortable to walk in the door. And that's why I'm putting Christy and Cesar like front and center. I think if you can imagine being somebody who has experienced discrimination every time you walk into an ER or a medical setting, and it's very hard to walk in the door. And then you have these lovely smiling faces that learn your name and ask to pet your pet and get you harm reduction supplies with sort of very again, with sort of very warm and friendly energy while sort of asking you, what else can I do? I think that's sort of people's first touch. And then we have, the amazing front desk staff, Diane and Dylan and their colleagues that are not saying, you missed an appointment, sorry, you can't come here, but, how can we help you? Which service can we get for you? And then, Vanessa and all of the HAs that are letting some folks sleep it off in the corner and sort of triaging who gets roomed next. And then that's not even sort of mentioning our phenomenal providers that we'll thank at the end. But I think that that level of comfort around walking in the door is one. And then the second is meeting the needs of people who use drugs. We do have a number of people that are brought in by GLIDE or by other partners expressly for PrEP, but a lot of times PrEP is a consequence of a longer term relationship that was started because of a need for wound care or harm reduction supplies and sort of a conversation that was continued. And so I think being cognizant of sort of how to be responsive to what folks need and just be helpful in that way, I think can further everybody's goals. And then the third bit that Mary Shields and Jan Oscarson is really the brains behind this HAP operation and putting HAP into Word 86 have really done such a phenomenal job partnering with GLIDE, with Lion Martin, and a number of others to allow us to work with the community. So I will stop, I think, sharing that. Leave I think, our introduction there. Happy to take questions about this at the end. But for the rest of the time, what Al and I are going to do is take you through a few cases that are illustrative of the HAP clinical experience, hopefully share a few pearls along the way. And and then happy to take questions either about the clinic or about anything that we see at the end. So our first case is a 32-year-old woman with opioid use disorder on methadone at Ward 93, untreated hepatitis C, who was brought in by a friend for HIV testing after a sexual assault. So we saw this patient, and she was really lucky that her friend was a patient that had been working with Christy and Cesar to get harm reduction supplies and sort of found HAP as a trusted sort of clinical space because of that, and brought in our client here. And during our clinical visit, we learn that our patient was the victim of a sexual assault, which occurred about 48 hours ago that involved vaginal penetration without a condom. The person has unknown HIV status, and the patient hadn't heard of PEP, was mostly here for HIV testing. A bit about her. With regards to past medical history, she has, as I mentioned, OUD on methadone, untreated Hep C, had a history of early latent syphilis that was treated last year, and anxiety not on medication. She's living alone in an SRO and sexually active with women in a relationship currently. And we don't have a ton in the way of labs, but know she's had B immune last year. So, question for you all. You order the following testing after your visit: HIV, Hep B, syphilis, gonorrhea, chlamydia, trichomonas, and pregnancy testing. And the question is, what empiric treatment do you offer before test results return? I'm going to try, we'll see what, I don't know, you can tell me whether you're able to select all, but what of the following options are you interested in prescribing empirically? A, tenofovir, emtricitabine, and bictegravir. So Biktarvy is a single pill. B, TDF-FTC plus dolutegravir is another PEP option. C, ceftriaxone plus doxy for gonorrhea, chlamydia. D, ceftriaxone, doxy, and metronidazole for 3 of the STIs that are up there on the slide. And and/or E, emergency contraception. We'll give people a second. See what this looks like. Okay, so we have a spread. Excellent. So there's a split between whether folks are interested in sorry for the brand name, Biktarvy or TDF-FTC dolutegravir for PEP. And then we have more people voting for ceftriaxone doxy versus ceftriaxone doxy and metronidazole. And then many selecting emergency contraception. Okay, excellent. I love this. Okay, so this is a bit confusing. I've grayed out ceftriaxone doxy because I think that I'll go through the options. Of PEP options, the CDC would say TDF-FTC and dolutegravir is the recommended option as a single pill that is essentially approximating all three of those drugs. I think many of us use Biktarvy in practice, and there's been a good amount of data demonstrating that adherence may be actually better with Biktarvy as opposed to a 2-pill regimen, and is well tolerated and sort of effective in again sort of retrospective practice. So I think either of those options is great. With regards to do you need the metronidazole? Interestingly enough, if you go to the CDC guidelines that are linked down below here, trichomonas is one of the more common STIs isolated in survivors of sexual assault. Whether that was acquired during the assault or not, it sort of doesn't matter and is an opportunity to treat. But it actually is part of the empiric therapy guidelines for us all. So that I've sort of attempted to delineate in this somewhat complicated or sort of busy looking table. But I think that to summarize, the testing that many of you may be familiar with ordering in the context of considering PEP includes HIV testing. Hepatitis B may depend on vaccination, syphilis testing, GC and chlamydia, trichomonas and pregnancy testing. And then with regards to empiric treatment, based on the exposure, I think HIV PEP is a consideration for many. I think there is some debate in the PEP literature about when and how it should be offered, but it is commonly done, followed by repeat testing after the month of PEP. And then with regards to hepatitis B, if someone is unvaccinated, it's an opportunity to vaccinate. I think HBIG is only recommended if the assailant is known to be surface antigen positive. And then syphilis testing is there. And I think we've talked about the remainder of the STIs. And again, emergency contraception sort of based on risk of pregnancy. Our patient was interested in essentially all of the above, received Biktarvy for HIV PEP, ceftriaxone, doxy, metronidazole, and emergency contraception. She completed her antibiotics and follows up a week later and is doing well. Though she says that she missed a dose of the Biktarvy yesterday and is wondering about support for adherence. One pearl related to this, these are old data that include, this is a systematic review, this number is from a systematic review that includes, the days when AZT was used in PEP. But that said, in the systematic review, PEP completion after sexual assault was estimated to be about 40%. And that is as compared to sort of overall rates of PEP completion around 60%. And so I think that all of the strides made to think about how do we make this more tolerable, easier to take, and what else is there anything we can do to support adherence is something to keep in mind. But what I really want to ask you all or move us toward in terms of our next audience response question is thinking about HIV pre-exposure prophylaxis. So I was working with a trainee who, when thinking about what we were going to talk about with our patient during this visit, I mentioned PrEP, and she said, does she need PrEP? This was an assault. She has sex with women. She smokes fentanyl sometimes. She's working on cutting down, but not injecting fentanyl or anything else. What is her risk? Does she need it? And so I'm curious. I wanted to pose that question to you all. Would you offer this patient PrEP? No. As I mentioned, her HIV risk is with regards to sexual risk and IDU seems minimal. B, if you remember a number of slides ago, she has a history of syphilis and has Hep C of sort of unknown acquisition. So yes, she should definitely be on PrEP. Or C, I don't know. Okay. Okay. I love when there are spreads. We have B pulling away as a winner here, with most people thinking about that she should be on PrEP or have PrEP offered to her. And a good number of people appreciate the I don't know answer, and some say no. So I thought this is a really interesting question, and one that honestly has come up quite a bit in HAP. And I want to highlight this really, really great paper that was published in CID a couple of years ago. The first author, Nika Seidman, who's here at San Francisco General, that is entitled "Reimagining PrEP Provision for Women in the United States," but I think has some great pearls for PrEP use for all. And one of the paragraphs that I'm pulling out is about sort of adopting a universal education framework for PrEP. And I did not plan this, but last year, I think it was last year, when I was here talking about my experience in women's clinic and intimate partner violence, I talked about the universal education framework that's been sort of espoused in the IPV domain, acknowledging that when you're screening somebody or having a conversation about something that is sensitive, difficult to talk about, stigmatized, et cetera, disclosure may not be the one and only way that you move to the next step. That if you universally educate everybody and allow people to opt into the services they want, it may allow a lower barrier to engage with services that they need. So this was something that they wrote about in this article really nicely. And then the sort of most updated CDC guidelines for PrEP mention this, that we, I think, all as HIV and ID providers really value the conversations about sensitive topics and creating a safe space for our patients, and I think hope to assess risk in a way that is not stigmatizing. I think keeping this framework in mind, that it is okay to offer education about PrEP to all and allow people to opt in. And if they are sort of self-identifying their risk because they aren't comfortable reporting, say, sex work or injection drug use or what have you, that's an important frame to keep in mind. So what happened with our patient? She finishes her 1-month course of Biktarvy for PEP. All of her testing has been negative. As I mentioned, she was worried about adherence to the course of PEP, and Ward 93 was kind enough to arrange for the remainder of her PEP course to be directly observed with her methadone, or dispensed with her methadone. She did miss a visit for follow-up testing at the end of her PEP course. But because of our close relationship, I think that many of us have with our 93 colleagues, they were able to flag her to say, hey, can you please go back to those folks downstairs at HAP and have follow-up testing? And she came in for follow-up. Basically, I think a month odd after her PEP course, she has a conversation, sort of revisits what she wants to do with regards to PrEP. And after discussing risks and benefits, she elects to start TDF-FTC and wants to have it dispensed by Ward 93 along with her methadone. So proceeds with PrEP. And then a bit later, actually elects to switch to long-acting CAB, and she's completed her initiation, is doing great. And then we sort of moved from PEP to PrEP, and then the next thing on our list was her hepatitis C. And I sort of won't go into it a ton, but she had been living with Hep C for years and not previously ready for treatment. She was started on Glipib, also known as Mavyret, that is now also being dispensed at 93 along with her methadone. And so she comes to HAP to get her CAB for PrEP and is finishing her Glipib at Ward 93. And this is, we're sort of, she gets to decide, but she might transition to women's clinic for ongoing PrEP and primary care with Janessa, which is great. So that is our case one, sort of going from PEP to PrEP to Hep C treatment. And I will turn it over to Al for case two.
Great. Thanks so much, Ayesha. So I'm going to present case two. So this is a 32-year-old man with a history of bipolar disorder, anxiety, meth use disorder. His last use was about 2 months ago. Also alcohol use disorder in remission, who was referred to HAP to start PrEP. He reports 7 to 8 male sexual partners in the past 3 months. He's exclusively the top or the insertive partner for anal sex and reports inconsistent condom use. In terms of his meds, he's on lamotrigine and aripiprazole, which was prescribed through West Side Crisis, and recently started doxycycline for doxypep due to a history of gonorrhea and chlamydia. He's staying in a shelter, and in terms of his meth use, he smokes but is trying to quit. So the next audience response question is, which PrEP option would you offer him? Daily oral TDF-FTC, daily oral TAF-FTC, 211 PrEP, CAB-LA, A, B, or D, or all of the above? Let's see. Okay, so it looks like we have the majority offering all of the above, which I think is great. Also, folks, the second most common is A, B, and D, so the both oral PrEP regimens and CAB-LA. So the thing I wanted to highlight here is that now we do have evidence for 4 different PrEP regimens that can be used in men with sex with men. A, B, and D are FDA approved, but there is evidence for 211 PrEP, and it's in the ISUSA guidelines. In terms of the 2 oral PrEP regimens, TDF-FTC is now generically available and can be used across all populations. So it's often our first-line agent. But TAF-FTC is a smaller pill. So if people have trouble swallowing a pill, that can be beneficial. And then also it can be used down to a creatinine clearance of 30 or above. But it has been associated with small amount of weight gain, as well as some lipid abnormalities. In terms of 211 PrEP, it's only been studied with TDF-FTC, and it is a more complex regimen, so people have to be able to forecast when they're having sex and plan around it, but it could be a good option for people who really don't want to take a daily pill or get an injectable. And then finally, CAB-LA, we are really excited about. It's a bi-monthly injection that can be, that has been shown to be actually superior to TDF-FTC in phase 3 trials, likely due to adherence. It has been a popular option in HAP, but can cause injection site reactions. So we had a discussion with this patient, and he was very interested in CAB-LA. However, due to insurance issues, there was a delay in getting the CAB covered. So he was started on oral TDF-FTC daily, and we were able to get access to CAB. So he returned to HAP 2 weeks later, started CAB-LA, and tolerated his first and second injections well with no injection site reactions. So he returns 2 months later. He said he's restarted using meth, smoking daily. I was now experiencing homelessness and also has some pressured speech. He reports discontinuing his lamotrigine due to a rash, as well as his aripiprazole. But he is really interested in options to reduce his meth use. But he does say he's not interested in residential treatment for substance use. So the next question is, which treatment options would you offer him to help him reduce his meth use? And the options are contingency management, buprenorphine, sertraline, injectable naltrexone plus bupropion, A and B, or A and D. Okay. Yeah. So A and D, which is the right answer. The vast majority chose, and then also contingency management, which is, I think, a great option. So yeah, this just highlights the options that we have evidence for. So I'm going to talk a little bit about this. First, I wanted to highlight this really excellent article in New England Journal of Medicine Evidence by Philip Coffin at the San Francisco Department of Public Health and Leslie Swen at UCSF. And this article highlights or reviews meth toxicities, as well as really a novel approach to managing meth use in clinical practice. And it highlights both using a non-judgmental approach, strategies to reduce use, both non-pharmacologic and pharmacologic measures, as well as addressing meth toxicities, cardiac and neuropsychiatric toxicities, and finally, a number of other prevention measures. And in the article, they review several non-pharmacologic interventions for meth use disorder. And really the one that has strongest evidence is contingency management, which is a behavioral approach that uses motivational incentives to support positive behavioral change, such as having negative drug tests for stimulants. And in a recent systematic review, which you can see here, they identified 7 studies of contingency management, and all of them demonstrated positive benefit in terms of reduced meth use or prolonged abstinence. I believe we're in the process of trying to get contingency management available through Ward 86, but it's also available now through the Bridge Clinic. And so patients can be referred there. And while we don't have FDA-approved regimens for meth use, there are several promising off-label pharmacotherapies, which are shown in this table. There's 2 that I wanted to highlight, which I think have the stronger evidence. The first is mirtazapine, 30 milligrams a day. This was studied in 2 placebo-controlled phase 2 trials in sexual gender minorities. And they both showed reductions in meth use, as well as reductions in sexual HIV risk behaviors. And then the other one I wanted to highlight is a combination of injectable naltrexone given every 3 weeks, combined with high-dose bupropion. And this was studied in a phase 3 trial in people with heavy meth use, so moderate to severe meth use disorder. They did combine it with incentivized payment using video directly observed therapy, but it did show a significant reduction in meth use in the study. So I think those are the ones that people highlighted. Other ones that are shown here are bupropion or naltrexone alone, as well as amphetamine type stimulants like methylphenidate. So going back to our patient, at that visit, he was given his 3rd CAB-LA injection. We did a warm handoff to the Bridge Clinic. And at that point, he was interested in contingency management, so referred for those services. And then in reviewing the options, he was interested in starting IM naltrexone or Vivitrol. And the team was considering adding bupropion to that, but they wanted to consult with Westside Crisis about getting him stabilized on the aripiprazole before starting the bupropion. So he returns 3 months later to HAP. He's now street homeless. It's been 11 weeks since his last injection, and reports trouble getting to clinic, but is interested in continuing CAB-LA. So the next question is, what would you do next? Would you discontinue further injections due to concerns with clinic attendance and missed injections and prescribe TDF-FTC? Would you attain a HIV rapid test and if negative, administer CAB-LA after, but also give him another loading dose in 4 weeks? Would you get a rapid test and then administer CAB-LA and just resume every 8-week dosing? Would you get a 4th generation HIV antigen antibody test and HIV RNA, administer CAB and give them a loading dose at 4 weeks, or get a 4th gen RNA and then resume Q8-week dosing? Lots of options. Okay, and interesting, we do have a spread here. And it looks like more folks are selecting the 4th gen HIV RNA, administering CAB-LA, and also giving him another loading dose. But some would also do a rapid test and then fewer just resuming Q8-week dosing. So I think the guidelines actually suggest E, which I'll go over here. So just to remind folks for the injection schedule for CAB-LA, there's an injection at their initial visit and 4 weeks later, which is their loading dose. And then it moves to an every 8-week dosing cycle. The goal is to try to get the injection within plus or minus 7 days of the injection date. One thing that we're trying to do is sending a prescription for TDF-FTC just to cover backups, that have it available at the pharmacy in case people can't come in for their injections, that they have that available. In terms of missed injections, the guidelines say that if it's less than 4 weeks late, so if they're on a 8-week cycle, less than 12 weeks, then if they do have access to TDF-FTC, they could start that when they miss if they miss their injection visit. When they come in, sending a 4th gen viral load and then administering CAB as soon as possible. If it's more than 4 weeks late, then also obtaining testing, and it's in this case, it's good to try to get it within 7 days prior to the injection. And then that's when you would reload if it's over 4 weeks late with a 4-week injection and then returning to 8-week intervals. So the next case we wanted to present is a serodifferent couple who presents to HAP. They were both seen initially at City Clinic back in early 2024. We're just using made up initials. AD tested positive for HIV, whereas SH tested negative for HIV and was started on TDF-FTC PrEP. They had a very complicated family situation where they had recently lost custody of their 3 kids, and so they were very concerned and really focused on trying to regain custody. So the male partner was the one who tested positive for HIV. He had a rapid start on Biktarvy. CD4 was about 250, viral load 1.2 million, and was referred to Ward 86 for HIV primary care. And as I said before, the female partner was started on TDF-FTC PrEP. So the male partner was contacted by the FAST team, which is a rapid response team to rapidly get people linked to care for people who are newly diagnosed, and also a links navigator, which is available through the health department. And at that time, he said he wasn't interested in primary care. He was really concerned about just housing and family reunification. But the links navigator continued to follow up with him over the next month. He needed to go to several social service appointments, and so they provided transportation to those visits. And when they were talking to him, they talked about U equals U and the other benefits of treatment. And he slowly became more open to primary care. And he was told that he could drop into the Ward 81 HAP or the lobby, and that also transportation would be provided by links. So he actually comes in for his first HAP appointment. He's living on the street. He had reports being off of his Biktarvy for the last month or so. He said he was really fearful of needles, did not want long-acting treatment, was reporting using meth and cocaine daily. And so at that point, they restarted him on his Biktarvy, and the plan was to repeat his viral load in a few weeks. And the female partner was accompanied, she came in with him to that visit, and initially declined a visit on her own, but then was open to it, reported that she had run out of her PrEP. And so Christy, our amazing nurse, provided a Mediset with a supply of PrEP. And she understandably was very concerned about just regaining custody of her kids as well as housing, and was also looking for employment. And so they were both able to see the HAP case manager that day, and then actually came in weekly over the next month to see the case management team, still supported by the Links navigator who was helping to provide transportation to the visits. And then they were working with another navigator in the community at Shanti to get the patients into a hotel. And they were able to successfully do that into a Positive Resource Center hotel, which was a 2-week stay. Meanwhile, the male patient was admitted had a hand abscess after an altercation, but left AMA, and then went to a series of different emergency rooms, but really due to the long waits, was not able to get full care there, left without getting antibiotics, did drop into the HAP clinic at that point, was able to be seen by a provider who provided antibiotics, looked at the wound, and was on the street again. So was able to see the case manager for temporary housing placement as well as provision of food. And then the Links continued to support providing transportation to visits and was working with the Ward 86 case manager to complete the housing paperwork. So he follows up in about a month. His hand is improving. The case management and Links were able to get him into DPH stabilization housing, which was for a month. And at that point, he was reporting good adherence to Biktarvy, and his viral load was about 2,600. Meanwhile, the female partner comes back to HAP in May, this time endorsing severely depressed mood, disordered sleep, anxiety, frequent crying. And so was referred to the Harm Reduction Therapy Center, started on citalopram, but was reporting that she was actually being able to take her PrEP, and they were actually supporting each other in terms of their medication adherence. And over the next few months, they continued to be supported by the HAP case manager, helping with their housing needs. She started a vocational rehab program and was at some point granted visitation with their children, but the story is continuing to evolve. And I think what we wanted to really highlight with that case is just the really important role that case management social work can play in supporting patients through their journey, as well as just working collaboratively with service providers in the community.
Thanks, Al. Okay, I'm going to give you a very quick last case, and then we'll share a few research highlights from Al. This is a 44-year-old man who came into HAP with untreated opioid use disorder and partially treated chronic hepatitis C, who was brought in by Glide for Hep C and OUD treatment. With regards to his Hep C, he was diagnosed in 2019, genotype 1A, no cirrhosis, and started treatment with Sofel in 2021. Took for a bit over a month and then lost housing and stopped. Did not achieve a virologic response, and a subsequent viral load that was Hep C viral load acquired in 2022 demonstrated was positive 1.2 million and same genotype. And then with regards to his OUD, he's been injecting heroin, using opioids for many years, injecting heroin previously, and then has been smoking fentanyl since 2020. He's tried both methadone and buprenorphine and prefers to be on buprenorphine for the flexibility. And so last ARS question for you all is, what would you recommend to treat his hepatitis C? Would you pick Glipib or Mavorite for 8 weeks because his Hep C wasn't genotype 3? B, are you thinking about Sofvel Vosevi for 12 weeks because he took over 4 weeks of Sofvel previously and didn't have a virologic response? Or C, I don't know, ask Dr. Jess Briggs for help. Give everybody a second. And yes, as a reminder, if you were wondering, what was his experience? He took Sofvel in 2021. Okay, I'll go to our ARS. The majority of people are opting for Sofvel Vox, and some opting for Mavorite, some opting for Phone a Friend. And I'd say that my favorite option is B or C. I was being a bit tricky, but I think with regards to how an approach to sort of folks with Hep C treatment experience, I think one time threshold to keep in mind is less than 4 weeks or greater than 4 weeks. He had been taking his prior regimen for greater than 4 weeks. And if somebody had been taking Sofvel for greater than 4 weeks, and you will want to use Vosevi. And I'm happy to talk more. There's some more permutations that essentially I always look up, but that is what we selected for him. And the plan was for weekly med pickup until he's connected with Shanti Hep C navigation. And for his opioid use disorder, the excellent HAP provider prescribed low-dose buprenorphine, a sublingual start. And just as a reminder, the outpatient pharmacy at the General will bubble pack the first 3 days of a low-dose sublingual start. And you can look on sort of my favorited orders if you want to steal that order. I believe either Amu or Janessa had done that. And our patient was just, it took a while to pick up the sublingual buprenorphine, then acquired it, but had not made it through all the 3 days. And then when he came back for follow-up, he was just described feeling sort of overwhelmed. And oh, sorry, some of the colors did not come through here, but my teaser that I'll leave you with, because we'll hear more from Bridge Clinic in 2025 when they come to HIV Grand Rounds. But we have a new option for buprenorphine starts. Many of you may remember either me or Paula Lum or others telling you like these very complicated start regimens for buprenorphine that overall people their eyes start to glaze over. And I think excitingly, there is a long-acting buprenorphine. I think as excited as we are about long-acting HIV prevention and treatment options, I am similarly excited about this long-acting MOUD. This second generation extended release buprenorphine option comes in both a weekly and a monthly formulation. And that weekly formulation has just really nice pharmacokinetic parameters, and then it sort of increases relatively slowly. So folks can come in after not having used for around 12 hours and just in a little bit of withdrawal, but not too much, we don't need to require too much, and get an injection of this weekly buprenorphine that allows them to hopefully have a smoother start. I think my big take home, I'm not providing you a ton of details here, but I will say, and I'm so sorry this is Black, but one of the really wonderful parts of working in HAP is getting to partner with Bridge Clinic. So what happened for this gentleman, he received his Brixadi, his shot from a HAP provider, and then followed up with Bridge when folks had questions. And so the Bridge Clinic providers are phenomenal and they're available. I think if people didn't know, and as of the last few months, they're open Monday through Friday, every day, have drop-in hours, either 1 or 1:30 to 3, and then have a Thursday evening clinic. So have drop-in hours 5:30 to 7 p.m. in the evening. And so there was always a close partnership between Ward 86 and Bridge. We could always send our patients there, but I think that sort of even lower threshold, given the availability, you can either refer to Bridge or have people drop in, or both. So stay tuned for more on on these bupe formulations. And I'll turn it over to Al to end it.
Okay, so we wanted to end with just sharing a little bit about some research that's happening within HAP. One of the projects is a Gilead-supported grant through one of their NOVA mechanisms. And this is really to help refine the HIV prevention services that we're delivering through HAP. And so what we're doing is we're interviewing about 12 to 15 patients or clients, as well as 5 to 7 HAP and GLIDE providers and staff. And really the goal is just to get feedback on HAP services, what's going well, what additional services people are interested in, as well as what strategies could help them engage and continue to stay engaged with the HAP. And once we identify some strategies, we want to pilot them within 50 people who use drugs within the HAP. We're also really open to other research ideas and projects. So please come to talk with either Ayesha or me if you're interested. But we have started the interviews. We've done 5 so far. And so I just wanted to share some early preliminary findings. First of all, I think the resounding theme is that people really like the staff at the HAP. And when we have a question about like, what do you think is the most important thing? And people say it's the staff, that they're relatable, they're non-judgmental, caring, welcoming, and that's really a key ingredient. Also, they really like the hours, the afternoon hours are helpful. They actually suggest having longer hours, kind of into the early evening if possible, which provide better access. And then pretty much universally, people reported some issues just getting to the clinic, transportation. And so they said, you know, if there was Uber or Lyft, that could help them get to the clinic, or even taxi vouchers or even bus tokens, that would be helpful. There's also, as we heard, just low awareness about PrEP in the community and need for additional ways of getting the word out about PrEP. We talked about different ways of supporting people taking PrEP. And people actually liked the idea of text messaging support. We have a program called PrEPmate that has been tested in other populations, and people so far seem very interested in it, but they did say that sometimes they lose their phones or they lose service. And so if there's assistance in providing cell phones or support for cell service, that would be helpful. People also were very enthusiastic about incentives and said that that would be really motivating to attend the visits. And finally, just case management support has been critical. I have a few quotes from some of the initial interviews and talking about the HAP staff. One participant said, they're a breath of fresh air. They are so nice. You can tell they care. It seems like this is their lifelong jobs. They're doing a job they want to do. I've seen what they have to deal with, and they do it very well. It takes a lot to put up with people who are screaming in your face, and they do it with a smile on their face. Another participant talked about barriers to HIV prevention, and this participant said, I think people are not aware. And this person was talking about hearing about it through their roommate. And so they said, if I wasn't staying with that person at that time, I would have had no idea where to go or what to do. I could have HIV right now because I had no idea that it even existed. And finally, on social work assistance, the social worker here actually helped me get housing, and they first helped me get into shelter after the assault, so I wasn't on the street. And then a little while later, they helped me get into a temporary room. And in terms of awareness, to address low awareness, we're working with a local artist and activist, Fabiana Rodriguez. She does some really beautiful art, and she was really interested in creating a campaign to help educate and raise awareness around PrEP, and focused on the communities that we're interested in, including people who use drugs and people experiencing homelessness. So you can see some examples of her work above. And then she started to create some sketches, which you can see below, and she's working on finalizing these. So we hope to have them available early next year. And this is a project that's supported through CHAP, through the Department of Public Health. And it's also a collaboration with East Bay and South Bay Getting to Zero. So it's a regional collaborative. So just to conclude, the HAP provides low barrier drop-in access to HIV prevention and treatment, Hep C treatment, access to harm reduction and substance use, housing support, and mental health and behavioral health. So really a wraparound holistic approach. There really is a need to increase PrEP awareness among people who use drugs and people experiencing homelessness. However, there is a substantial interest in PrEP among people who use drugs. And I think we've seen particularly interest in injectable PrEP, but we do need ways to increase persistence. And finally, support from case management and warm handoffs with Bridge Clinic, along with collaboration with Links and other community providers has been really critical. And I think Ayesha will end.
Oh yeah, and then we just wanted to conclude by Al and I are just two people talking about our HAP experience, but as I mentioned earlier, I think that this the decision to include HAP within the Ward 86 family is like really thanks to Monica Gandhi, Jan Oscarson, Mary Shields, who's like really created the structure of this, and then Christy Camp and Cesar Arroz Cuadro, who've been like the heart and soul of HAP for the last number of months, along with our phenomenal providers, Stephanie Cohen, Janessa Broussard, and Amu Rajapal. So we're so happy to have her. And then just, again, a million people on this list, but really thankful for case management via HP, our phenomenal pharmacy team, Maddie from Benefits, that is providing such a phenomenal first sort of contact with patients, as well as the Bridge team that Al works with, and Glide, and then Pop Up, who we're modeling so much after. So thank you all, and happy to take questions.
Thank you. I feel like those quotes really, their lifelong journey as providers is amazing. Thank you to all the HAP team for the work. We'll take some questions. We'll start with Gabe.
That was great. And just a huge thank you to the HAP clinic and the leadership and all the team members for this. Is amazing. I was just curious, thoughts on what is working or not working in terms of PrEP awareness, because it seems striking to me that it's still so low. And the second thing is about follow-ups for people on injectable PrEP at HAP. Given that as drop-in, I mean, to what extent what are your outreach efforts, particularly for people that just don't show unhoused, not in primary care, and trying to get people back and being aware of missed visits and the long tail? Thanks.
Yeah, that's a great question. I think first I'll be curious what Al thinks too about sort of citywide awareness of PrEP among people who use drugs. I think that we have thought about, can we do, we are like partnering with harm reduction organizations. And are there ways to sort of get farther into the community and do more? I think in additional to the harm reduction orgs, I think one thing we've built over the year is partnering with our addiction treatment facilities too. So I think like more partnership with Ward 93, Bridge, OBIC, et cetera, I think has allowed people a pathway that also hopefully is increasing awareness, though again, sort of relies on people accessing those services. I can get to your second question, but Al, do you have any other thoughts?
Yeah, I mean, we've been doing some more interviews through other projects just about what people think about ways to learn about it. And it's really through trusted peers and trusted providers and they may be, outreach workers or just, peer navigators. So I think through trying to leverage those strategies will be helpful. And then just, I think, we are trying to develop the materials that we showed, but then also, I think there've been some looks at, whether people are engaging in care in other settings beforehand. And I think, if they're any touch point, I think is a great time to bring up PrEP through their providers.
And then, yeah, I love your second question. I think that with regards to sort of how do people stay engaged in long-acting PrEP in a low barrier setting. Thank you to Matt Spinelli, who's our PrEP lead at Ward 86, who's done a really wonderful analysis of like sort of essentially looking at the PrEP care cascade and persistence in folks on long-acting PrEP at Ward 86. And as we were showing you some numbers, there are 30 people on long-acting PrEP at HAP, and there's 26 people on long-acting PrEP upstairs in Ward 86, and there's actually no difference in persistence. And I think a lot of that is thanks to Christy Camp calling people and texting people, and then our amazing pharmacy team as well. We thankfully, most people actually like have phones and are responding at the moment, but I think a mobile element, and we've like talked about what might be helpful in the future. And then I think a big problem that we have seen is that there was, if you remember, there's a big number of people that we've ordered or wanted to start PrEP that haven't come back to start it. And so can we do better with same day? And I think with Len, I think it'll just be very interesting. I'm really excited about that possibility and developing more there. But yeah.
Great. We're going to do 2 questions from the chat. Is that okay, Monica? And then we'll come to you. One is from Annie Lukemeyer. How well does Brixadi work for pain?
Oh, great question. We don't know. I wish we did. I hope that somebody is evaluating this. I think theoretically, the way that buprenorphine for pain or methadone for pain or any of these sort of double duty medications are being used are like multiple peaks throughout the day. So I think there's some concern that if you have one dose of a long acting opioid that's sort of falling off over time, is it going to be effective? But I'd say anecdotally, different people feel really differently. So I wouldn't advertise it as it is certainly not studied, but I think theoretically could be an option if someone's open to trying.
Great. And then the next question, you talked about how HAP is an open door and a walk down the hallway. And so Sunny Lai is asking, how do you transition people to other clinics? Are they amenable to leaving the space? My impression is, people end up engaging and it's hard to move, especially if it's not as convenient or the resources aren't there, aren't the same.
Yeah,
so how do you do that? How have you done it successfully?
Great question. I think that it's because I think the only reason it has been easy in the majority of cases is because of how phenomenal pop-up is. Like, because pop-up, we can transition people to another low barrier model and that has shared staff, many of the same providers, nursing team, and sort of ethos in the clinic. That has been one easy step for people that are sort of came in the door with viremia. It has been hard to figure out what, as Liz and I have talked about this a lot, and I think many in our clinic, what to do with the folks that are suppressed, but yet have an active substance use disorder, mental health concern, experiencing homelessness, and really have a lot of life instability that would be best served by a low barrier model. And sometimes, we've had some people go to SFHCC. Some people have ended up at MXM, but that is a bit hard, and I think that's something we're still working out.
I just wanted to say that I was surprised by how shockingly crowded HAP got and how much people need low barrier access care, because I didn't think that it would be like this. And maybe we should have known that from pop-up, but it does. And it's also partially because you are also amazing and you are so smiley despite being yelled at. But I think it's really important for us to think about Ward 86 and it possibly in a different way about appointments versus like just this kind of model, maybe for almost everyone. And I think it's HAP and pop-up are going to really inform how we deliver care over the next 5 years.
Yeah, I think that's such a great point. The flexible nature and allowing people, yes, to not feel like they have disappointed someone by missing an appointment is really important. And I think many of us have talked about, Liz and I have talked about this too. There's a group of people that sort of would be served by having a low barrier model, potentially with fewer sort of intensive wraparound services, but I think that there is potential for sort of an in-between model that would be really interesting. And yeah, I think that I think it really is a combination of those two things. I think one of the biggest the most satisfying thing I've seen, which has happened a good amount. I'm looking at my the HAP nurses in the back, but when patients bring in other patients, I think that was been a good sign of like, oh, I think this has become a trusted space, and I think that's all due to our team in the back there. But yeah.